just click full screen located in the bar above the presentation window and click it again if you want to exit. Handouts of the presentation are available to download from the handout window. You might need to disable your pop-up blockers to retrieve them. The presentation will get sent to me, the moderator, and I'll read the questions to the presenter at the end of the webinar. To obtain CME Main Pro M1 or Maintenance of Certification Section 1 study credit, desktop for attendance form at the end of the presentation. Please complete the evaluation form. That really helps us plan our next programs. Again, you might need to remove your pop-up blockers to access those forms. Involves support and treatment planning for physicians who are experiencing difficulties related to a variety of complex psychological and medical conditions. Dr. Farnham's medical career has spanned the fields of busy family practice, occupational medicine, and addiction medicine. Paperwork and forms associated with their patients' time lost from work. Dr. Farnham is a clinical associate professor with the University of British Columbia and a faculty member of the Physician Health. Welcome, Paul.
Thank you, Selena. It's good to be here. Thank you very much for the invite. So we have a safe return to work for my patient. Who do I talk to? And I put what should I say, because it's been an important topic for me over the years in my days as a busy general practitioner who was also doing part-time occupational medicine. So disclosures, I have no financial disclosures, no disclosures to make whatsoever. And disclaimers, my wife always tells me to emphasize that the views that I express are my own, so I'll do that to make sure I'm would be very simple. They would be grateful, and they wouldn't have paperwork. And I learned from my own practice and from my involvement with physicians that this whole business not going to work or not wearing a seatbelt or not doing something. And now it seems that people want notes to go to addition, but I thought what we might do is just look at a question and see what folks thought about this. So Dave is a 30-year-old Safeway employee, and he fell snowboarding 2 weeks ago, and he injured his left knee. And this is his first visit. My work wants clarification of my diagnosis for light duties. Can you call Mike at this number and explain the diagnosis? Okay. Okay. So I hope you Alex, can you move this off my screen? Yeah, perfect, thank you. And let's see, we'll have another scenario. So Dave, he's always injuring himself. He's fallen for the last 2 weeks to protect me against this employer who has an aggressive return to work policy. So do you give a note declaring disability to the union representative with Dave's consent? Okay, I'm not sure if you can see it. So seems about 75% says don't, and about 25% says that we should. In the world that I work in, and certainly with HealthQuest, we see a lot of people who work in safety-sensitive positions. Safety, safety, safety is everything. And communicating that some folks use in the workplace and in the insurance industry are not all the terms that we're familiar with. And we'll talk a little bit about these words: disability, what they mean, restrictions, so forth. Organized, and we really need our office to keep us in check, and most docs don't have an office process. They would like to do this better. They try to do it on a one-off basis, but I would like to emphasize the importance of our offices having a system. So we are by being at work. People who are not at work, who are disabled, who are away from the workplace, enjoy poorer health. The Canadian Medical Association, the American Medical Association, so we do nothing to benefit our patients by prolonging a stay away from the workplace. And physicians, therefore, need to encourage the patient's return to function and work as soon as is reasonably possible. To help our patients to understand that. And a lot of how our patients interpret their status or how well they're going to do hang these many groups of people that are involved. Let's take a step back and think of the traditional way that we've done this over the years. Is we have the doc, the hierarchy. We should go back to work and so forth. And in fact, if you speak to the employers over the years, they'll say that they've watched this, they've observed this significant or he can't go back to work. And it was a very black and white, cut and dried thing. It was a back on the ice. Okay, so same analogy. It's not an all or nothing response anymore. And I think physicians, in understanding that to some degree, opted for what they mean. The workplace has a totally different understanding. The patient has a different understanding, and that's one of the ways that folks can get into trouble. They see is this. They think that over the years they're getting squished out of the ironic ironically, what's happened with the employers is there's actually more legally defined obligations on them to provide a better workplace and to be more involved. So they are obliged to provide a safe workplace and help me to come back to work. That's their obligation. Now they have to do that up to the point of what's called undue hardship. So I can't go back with, for example, an example might be that if I, if I lose my eyesight for some reason and I still want to for the employer wouldn't be obliged to hire another bus driver just to fill in for me and so forth. But these are important terms that we don't get raised on, we don't necessarily understand, but the because they're instructed often by arbitrators and other people that they need to become what's called an informed employer. In other words, they need to know enough about the information and treatment information, etc. And we're going to talk about that a little bit more. So there's some challenges, and if you're an employer, it can be quite difficult to try to decisions. So if we look at that old model, another key player that we often don't want to like, or it appears that we don't want to like, is the insurance carrier. We don't want to hear if they get injured. The insurance carrier BC. So the insurance carrier is actually purchased by the employer. So when a worker says I've paid into WCB for years, the worker doesn't pay into WCB. The employer pays WCB. The employer piece of the puzzle, the insurance carrier, and as we will talk about again just a little bit further on, is they need good conditions. You're aware of how stressful it can be for whole families. A worker does well in the long term will be people at the workplace. One place, and everybody at it knows what everyone else is talking about. But these are all different people with different roles: co-workers, unions, supervisors, managers, the human resources department, the labor relations department. So very different people, but all potential and so forth, all may play a significant role in returning folks to work. CPP pension. More recently, and they wrote a nice summary policy about the physician's role in helping patients return to work after illness or injury. And I just selected the 4 highlights that they emphasize that patient. And again, it's advising and supporting. Really, really important, the positive effect that we can have on our patients. Not our job to block information to the employer. There's appropriate safe and timely return to work. That policy was adopted by the Occupational Environmental Medical Association of Canada, and this is the American statement, which is similar prevention. They actually know the workplace far better than we'll ever know the workplace, and they emphasize a model of the healthcare professionals, the HCPs, work abilities and safe placement based on the input from the health professionals. And they emphasize in a timely fashion, because if they're away from the workplace too long, a lot of things, negative things happen, including, out of sight, out of mind, loss of connection with daily and the employer need to talk with each other. They need to sort out a lot of the problems. Healthcare professionals are ultimately consultants to that partnership. And insurance carriers are critically important, connecting with okay? So when you think of them as somebody who just denies and claims and defense, the claim is processed and paid must be objective, impartial, and reproducible. So that means if I provide medical evidence on an individual who is ill or injured, it should be reasonably expected that another physician as I say, they need to be reproducible. And I remember after realizing this, objectively fill out findings and objectively document what I see. And it's important for them to know that, because patients often think that we will over-advocate for them, and they need to know that that's not going to be the case. The claim. It's not your job or my job to adjudicate the claim. It's our job to provide them with the information to adjudicate the claim. So they're entitled to that. Let me show you some samples of saying I know his family, he's a good guy. Saying if he says he's unable to work, I believe him. We really need to remember our professionalism. Insurance carriers need good medical information. They value good medical information, and we need this is a couple of full slides, but I have done that because they're quoted particularly from employer is entitled to know, was the employee unfit to perform other suitable available employment during the absence? Was the employee unfit to perform Are there medical restrictions on the type of work which the employee can perform? And will the employee's medical condition be likely to cause any absenteeism in the future? When you speak to needs and is entitled to, and who says this? Who says this is the complaints to our college is actually people are looking for information to try to help a worker at work or get benefits, and they don't get that information from the physician. And it's surprising when you speak to the college how many identify and incorporate new communication strategies for discussing work with patients who are sick or injured. These again are from our learning objectives tonight. And as I reflected on that, there is no more important person to communicate in how we say it and what we say to the patient who is worried, scared, or put on a work boot again in your life, is going to be something that's really going to be hard to turn around later down the road. So we need to be very careful. So let's reflect on a few thoughts about assessment, diagnosis and treatment. Is our patients are entitled to, in as much as possible, timely assessment, good diagnosis and treatment. And it's so informative to ask early on, ask the patient what plan normalizes and helps patients to appreciate that this is part of normalizing my life. The If all I can find is non-specific low back pain without anything else, then I need to say that to the patient. In our office, we sometimes see folks coming through, they've had 4 or 5 MRIs, tremendous worry for a patient, when sometimes it's right to say, you know what, this is a non-specific low back pain. I know we can deal with this. You know, I think that's not a bad number. That's not a bad figure. I don't know if many of you have had surgery or been ill or been away from the workplace. Most physicians aren't away from work for very long, but 6 to 8 weeks. The key points about communicating with patients, again, just in kind of bullet form. Patients need to hear that work is known to be therapeutic, and it's actually an important part of rehabilitation. It is. Common health problems, much of this should be preventable, and we have advising to stay off work is actually a major clinical intervention, and it has potentially serious long-term consequences. Sometimes it seems easy in the office to say, I haven't figured this out. can often be accommodated at work, if necessary, with appropriate adjustments and support. And as I said to you, the employer knows they have a duty to try to help facilitate these types of accommodations. We focus on remission of symptoms being the goal, and we I think some key questions I often like to ask patients is what is it that's actually preventing you from getting back to work right now? And you can't manage the workplace or guarantee that you can get that job, but it's interesting to get the patient's opinion. And emphasis discussions about what the patient can still do rather than what they can't. Emphasis on ability. So, diagnosis and treatment, it's our job to inform the patient for sure. To help the insurance carriers, that's well defined. But providing the diagnosis and treatment to employers is not something that we should be doing. We need when we start to write to or communicate with workplaces or insurance carriers, some of their language is a little bit different to ours. We're really good on diagnosis and treatment type languages. But these terms with regards to the referrals that come through our office, for sure. So, impairment. Abnormality of function, I could damage my wrist, my hand, my leg. It could be physiological, I could have impairment, renal impairment, function, or psychological. And it should be clinically observable. Now, disability is a whole other thing. Disability is about a lack of So at this time of the evening now, this slide is getting a bit difficult, but bear with me. I do want to emphasize the key differences between impairment and disability, because this is where I see some of the worst to do certain things. Right? So let's see this is hard with a group that's not in the room, but I'm going to see if we can try to clarify what's the difference. I don't believe we need to write very much. We have a clear understanding that we're all on the same page. So impairment, but it's not automatically a disability. So I went to a concert with my daughter last Sunday. I had a temporary impairment of hearing afterwards, the loudspeakers. I wasn't disabled. Task it's temporary or permanent potentially. If I was a telephone operator and I had hearing impairment after a rock concert, I might have a quiz. So a quiz is that there are two prominent celebrities that I think you'll know. They're touring BC and they sustain identical injuries in a Prince George sawmill. They both lose wants to know if they're which one is impaired and which one is disabled. And you know that impaired was in Prince George, Peter Mansbridge, and Eric Clapton. Now, Alex. Okay. So about it's going between 75-25, 80-20. I would assessor to assess impairment, they would probably say there's the same loss of movement and loss of function for both of those individuals, that they both have the same impairment of function. Alex, can we? So Eric Clapton probably has an excellent disability package, by the way, is technically disabled. I think there is very little reason for us to write the word disability, yet I see it on notes all the time. My patient is disabled, and then what really sounds stupid is my patient is disabled. I think that we're really quite disorganized and we don't understand. So that was a bit of extra time on disability, just to emphasize that. So medical opinions, we're going to joints can move and so forth. And the problem for us as family physicians is we want to advocate for our patients, so it sometimes gets the objectivity. And most people don't know what their patients actually do at work. So communicating with employers, insurers, I think a key question is when you're asked about sending information back to a manager or a supervisor. But I prefer to put information in writing because then I know that that's what I've sent. I've been burnt on one or two occasions when someone misquoted me on the phone and it went to I think it's good for family physicians to try to use a standardized form, either in their own office or a standardized format in their head about what am I trying to send back here. Though maybe patient's consent. Sometimes the patient signs a consent to send everything off to case. So sometimes you need to check that. Or if the patient says, you can send everything to work, you may need to remind them, do you really want the information about the affair you had last year sent off to? So you need to help them understand what's appropriate. High quality work, you will get paid for it. Final thing I've learned is nothing is off the record. So speaking on the phone to somebody at the workplace and having a little subtle gossip speaking on the phone. And there's my emphasis. In many ways, I don't think I've written the word disability what the person does, and I will always try to think in terms of ability. Right? And please eradicate the term light duty, because there is no definition that I know of what light duty really means, and sometimes with good, innovative ways of helping people back to work. And in fact, the people who often want to be at work don't even show up looking for notes, because they have a good relationship with the workplace and they know how to get back to work and what they can do for this many weeks and what they can go on. Health nurse, return to work medical coordinator. These are people who we can look at sharing some medical information should go to HR. This is a busy slide. It's out of a form I used to keep on my desk. It's when I didn't have a clue what the person's work was. If I did end up speaking at the workplace, trying to understand what the nature me what a tilt-hoist operator does. What percentage do they stand, sit? Do they do shift work? How long are the shifts? Quickly, are there potential or actual exposures to hazardous material? Do they have to wear personal equipment, protective equipment, should I say? And have they got other responsibilities? So they might be so do I know what they actually might do in their day's work? Because only when I know that would I be able to comment about how safe it is for them to go back to work. In our offices, I can't emphasize enough, and I think I learned this only are the physicians in a very disorganized way for them, so they produce them out of their pocket in the middle of the consultation and so forth. So I think there's a few thoughts about the office policy. One is everyone in the office should believe that early rehabilitation efforts are important. The approach should be the same. I think a written office policy is good because it helps staff appreciate what the policy is, and it also allows the patient to, because I think the college generally don't like you to ask for payment for services before they're delivered, but certainly I had a few patients who were that, you know what, you asked for a lot of forms, this will be the fee, and speak to whatever at the front and leave the form, and if you do that, I'll fill it out. And sometimes the forms never got left. In the middle of a consultation to write something that you might live to regret further down the road, and I've done that. I've it. I hadn't photocopied it, I hadn't recorded it, and as I say, everything I know in this, I think I've learned by mistakes. Your signature makes this a legal document. If you don't think you're worth it, in as much as you can in our office, the Society of General Practice, the BCMA, there's lots of resources to get written material. CMA emphasizes again a physician's assessment and signature on a third-party form have a value. I am in my head when I get asked to write anything about disability or return to work, all may be causing impairment, and is it disabling this patient from his or her regular work? And I might not be right, might be writing that, but I might not be writing it, but I need it to be clear in my head. And can he or she perform the essential her job, or his or her duties? Can they be accommodated? In other words, can I make some arrangement to have modified duties or hours of their own occupation? Right, so that's modifying their own occupation. Or if they hear the words restrictions, limitations, again I want to emphasize ability. The terminology restrictions, function, task and ability. Restrictions for me is should not or must not. Limitations are cannot. So if Tyler has a bad knee injury and he has an arthrodesis and he can't bend his knee, accident work or my regular work, and alternate work is doing another type of work. At the end of the day, early findings and opinions, objective, impartial, reproducible, and documented somewhere in my notes. So important. Have I considered safety sensitive issues? Again, my work now is before making any declaration about them returning to work. And does the risk of return to work actually pose a direct threat or indirect threat to the patient, to the co-workers, or the public? In fact, here's some better questions. What is it about staying away from work that's making this whole situation better? And what are the risks of me keeping that? In Prince George, and said he was asked to lift 900 pounds of lumber, and I started to write it down until I realized, there's machines that can't lift 900 pounds of lumber. So be careful what you hear. Another way to really get yourself into trouble is declaring disability without knowing the job. and really into trouble is telling the don't tell the truth or tell half-truths as a favor. Lots of evidence that we not objective, and they can get us into trouble. Writing letters declaring something you can't defend, I'm very careful about that. And ultimately, I have my professional integrity, and I want to be objective, and I want to be honest, and I need to hang on to that. Don't want to hurt you. Work is harmful. I'm in charge. Leave it to me. I'll manage this. And the new paradigm is different. Specify the ability. We are consultants to the workplace. Is rehabilitative, and a multidisciplinary team is important. We used to ignore the workplace demands. We figured paid absenteeism is entitlement, and build. And we need to build the employer, the insurance company, the patient for those pesky forms and those practical advice that's so important. And I'll just leave you with this slide that I used before, and it doesn't translate very well. On the bottom line, we can go to webinars and courses, and we can be able to define better what we should be doing, how to call things, returning to work. We can kind of contribute to that ongoing state of disability. So we owe it to our. I think we're out of time, so I'll leave it at that, Selena.
Thanks very much, Paul. That was excellent, and there's been a few comments already coming in to thank you. We have some questions here.
Yep.
The first question that came in is, what do you do about patients who come in 2 weeks after a problem is over and presenting?
He said, I need a note to say I was disabled for 2 weeks. Disabled or was unable to work. He could have been in Mexico. So what I would usually put is, Selena Dunn consulted my office with me in my office today, April the 10th. She reports that she sustained. I'm not going to wear it that I'm declaring that I know she was disabled or was actually injured, because I've seen it come back and bite folks that there was dishonesty.
Okay. Question, what do you do in the case of a patient who insists on staying in an accommodated position?
I think our job is to be consultant to the workplace. The job of the workplace is to manage the employees, and it's their job to decide where to place Selena. X and Y hours on this day, and I can't work other days. That's not my business, and I have to say, you know what? get asked to defend that, you can't defend why you think someone should do this shift or that shift. So the employer has a right to place people
and refuse to pay for completion of their forms, and you have a patient who's already off work receiving less pay, and the physician's concerned this is a financial hardship for their patient to have to pay for the form.
Yeah, I know, and I don't have any. That frustrates me. Fill things out because I do want to try to make sure the patient gets what they. You know, some of these we're not going to, you know, make on, and some of it you're adjudication on the claim, then the patient is not going to get no money.
Okay. What do you think you might do with a workplace that
Of so what I don't think you should be doing is saying, you know, Selena cannot go back to work until that supervisor. And I'm just very, very careful about it. I often think about when people come to me and say, I have a you should move out until we figure out, you know, how you should go back. Right? So we don't just, in some indefinite way, keep people away from the workplace. There is a particularly toxic work environment. If they had an occupational health nurse or occupational health doc, perhaps that might be something about people being harassed and working in toxic workplaces when I don't know all the details. And in fact, sometimes the work I want to be careful not to be jumping on one side or the other when I don't really know what's going on. That's not my job to sort out the workplace. It's my job to provide good medical information.
there's a couple of questions here about patients who are
So, well, if an insurance carrier, you know, and a lot of their sense of their disability is high, you know, after my examination, I have difficulty finding objective findings that correlate with these subjective complaints. So the patient, I'll probably have to paint that discrepancy and provide it to the insurance carrier. But I'm not going to be going
employers or insurers like ICBC or WCB to facilitate a return to work. This physician says he's found that problematic at times.
You know, as you work with the board, there's a wealth of knowledge with the MAs at the board, the medical advisors at WCB, to get them on the phone, get them working, and to resolve a lot of the concerns you have, move forward with those concerns, and then me, and I forget the last bit of the question. You had another piece of the question, did you?
That was really just how do you communicate with these people to get a return to work happening with the employer, ICBC, any kind of insurer?
Occupational health nurse at the site, or if they've got, because you can talk more and hear more and get a better understanding from another medical professional. That I think makes a lot more sense.
Stress leave. How do you address that? How
No, well, I mean, stress isn't in the, it isn't in the DSM-4. I think it's a dangerous thing to, I think it's a dangerous diagnosis to just jump to, because it often going on here, and what are you doing, or what remedial actions are being taken to try to address this. So I'd like to think that speaking sometimes to an insurance, this is a really important piece. So that would be some of my thoughts on that.
There's a few questions on forms that ask you to comment on a page.
This question always comes up, and I guess there's a spectrum between. There are physicians who feel comfortable making some common sense, recommendations about poundage because I haven't measured it, I don't have the skills, and I don't want to do it. And then there are, I don't know if they still do it, but I know Canada Post I'm not a huge fan of functional capacity evaluations. It seems to take an enormous amount of time to get them done. There are pages and reams of stuff that come out of them, and I'm probably upsetting somebody's feelings now, but functional capacity evaluation. Forms, I might try and ask to speak to the occupational health folks. If it's a work-related injury, I'll probably see could WCB help me out and do something to try to provide some
Because of our connection. So I'm going to pose two more questions. There are quite a few more that we won't be able to cover. Paul, would you be willing to answer them all? affect their safety at the work?
That's a really interesting question because it's so much of the work we do at HealthQuest. So let me see. Can I toss out a few thoughts on that? First of all, safety is the compromises safety in the workplace. Does that mean we have to go to the work site and say, Selena Dunn, necessarily I think have to say what it is. But if somebody's off work and then they want to go back and they still, and this happens a lot, for us to, if we're asked by the employer about someone coming back to work, it's reasonable to say, this person has a medical condition that I feel currently supporting them returning to work at this time or something like that. The other thing that we need to remember, and maybe we need to go back to that piece, but the other piece that comes into have health professionals in our practice who have active addiction or a mental health diagnosis that come. And this is not done well, and we need to be aware of that. And sometimes as we advocate for our patients, we think we're advocating, we kind of hide them out, we allow the addiction to go on, and they're stuck then for money, they're cut off insurance, and they need to get back to work, can actually save someone's life by saying, no, not only are you not going back to work, but we have to involve your licensing body here. You have to stop practicing.
Great. So for the last question, it's a question about forms. You'd mentioned an organizational system. Can you speak to the amount of content you need to write? Is a concise response?
Or what would I put in it on a notice in an office about forms? I wonder what that means. Well, I think there are documents. I've seen them, and I just can't reference them immediately. Announcing to the patients that these are uninsured services and clarifying what way the physician is willing to complete forms, etc. Oh, I think it can be. I think less is more, and it can be, fairly concise. So it can be as simple as, dear Mr. Manager, you've requested my condition that is currently impairing her ability to perform the essential demands of her work, and I currently consider her unfit for her regular duty. Make it clear to the workplace that there is a medical condition, but we don't have to call it. It could be diabetes, it could be cocaine addiction. increase at the moment, especially if it's safety sensitive. And if you look back on the CMA or the CMPA, you know, it might be reasonable to say it's my expectation that they may not be able to return to the but in the interim, they would be capable of doing non-safety sensitive work or
non-shoulder intensive work.
you know, get a relationship with your local medical advisor or someone, you know, make a connection with some of the insurance companies or OCDocs, and don't be afraid to ask before you write. I think that's the key. And it's not good. But most importantly, it's not good for the patient.
Well, thanks